And I guess most of us believe that treatment of hepatitis C will form part of the control of the disease, and that will include controlling the disease that you've heard emerging in HIV, HCV co-infected patients. And the problem is, if the stated aim is to treat millions of people with hepatitis C, we're going to have simple treatments, affordable treatments, and treatments that we can use where the resources are poor. We're not there yet. I'm just going to take you through a number of the current trials, some of the emerging data we have, and I recognize that I'm speaking from a somewhat unrealistic standpoint at the moment, but I would hope that if we're all knowledgeable about the way the therapeutics are developing, you'll see some of the problems that will guide us in the future. And I'm also really, there's a lot of work to discuss. I've just perhaps got about 30 minutes to do this, so I'm not going to go into details about the protocols. I'm going to oversimplify those, but try and pick up on nuances that I think are emerging at the moment with new treatments for hepatitis C. So where are we headed? The first is to talk about some shortened interferon regimens, interferon sparing in combination with new DAAs. And this is quite an interesting area because it is proving to be the classical licensing developmental pathway. A new DAA, for example, TMC435, a new protease inhibitor, second-wave protein inhibitor, will be licensed from a classical standpoint together with interferon ribavirin. That may not be how we use TMC435, either in co-infected or mono-infected patients, but these drugs needed to be obtained in this way. So just to go back a little bit in time, these are data from PROVE-2. This was a phase 2 study which looked at the first-generation protease inhibitor telaprevir together with PEG interferon ribavirin, that classical licensing pathway I'm talking about. And it had various arms, including a control arm, standard of care, but as well, telaprevir given for just 12 weeks together with PEG ribavirin for a further 12, but this perhaps quite interesting arm looking at just triple combination for 12 weeks, and of course in the European PROVE-2 study, a no ribavirin arm. And you'll remember the results. The no ribavirin arm gave very poor results. This puzzling, mysterious drug ribavirin is still necessary with the first generation protease inhibitors. Only 36% of patients had an SVR. And in this group of patients, without the tail of interferon and ribavirin, the results were probably inferior to those individuals who did get 24 weeks of PEG ribavirin versus 12. But a group have recently looked at that telaprevir 12, PEG ribavirin 12, so just 3 drugs for 12 weeks, relatively short period of time, in IL-28B/CC positive patients. And this audience will know IL-28CC is a genetic determinant cited at a locus upstream of the interferon lambda gene, which predicts interferon sensitivity, probably because it is a marker of the innate immune response and the interferon signaling cascade. And in the IL-28B/CC positive patient, the numbers are very small. It's only 12 patients. We're trying to put more patients into the analysis. A very high proportion of individuals had just 12 weeks of telaprevir, PEG ribavirin, and an SVR. And I think it tells us that there probably are quite an easy-to-treat group of individuals with shortened, circumscribed interferon regimens where this may be slightly more palatable and tolerable for patients. It's a short regimen. It looks very promising. We need more data. You can see for the TT-positive patients, this clearly doesn't cut it. The response rate's very poor. Again, the numbers are small. And again, of course, this was true in the PEG ribavirin control arms, IL-28B/CCs, around 65% response. So that kind of gives us a direction of travel and tells us something about interferon-sparing regimens in a group of individuals who have favorable responses to interferon. TMC435 is a next-wave protease inhibitor. It is not a true second-generation protease inhibitor. First of all, it's not active against genotype 3, and it's almost certainly, depending upon how we use it, it'll depend upon the regimen, it's not likely to be active against the first-generation resistance mutations that we are seeing with telaprevir and boceprevir. But it is a potent drug. Its importance is that it can be given once a day, so the dosing is important, and it is not associated with anemia. That's a big step up. No anemia with TMC435 compared to telaprevir and boceprevir. But it does cause some mild unconjugated hyperbilirubinemia, probably not of clinical significance. These data have just been published. They looked at genotype 1 treatment-experienced patients. Again, it's a phase 2 study. Phase 3 studies with TMC are well under the way. We should expect to finish those by the middle of next year, with licensing perhaps by the end of 2013, early 2014. But these are the data, and you can see some quite short interferon-sparing regimens. Here's TMC 435 plus peg-ribavirin for just 12 weeks. Different doses were used, 100 and 150 milligram, 24 weeks and 48 weeks, with some patients with cirrhosis being included in the study. And I'm slightly oversimplifying the demographics of these studies for our purposes today. And you can see that relapses have done very well, and they do quite well with quite abbreviated treatment arms as well, 85% response. Partial responders and null responders, nothing new in this, do less well with a peg-ribavirin protease inhibitor regimen. And that's because they initially did not have that intrinsic sensitivity to interferon. So these are the results we predict now. There's nothing spectacular about this. There's no new information that will redefine paradigms for treatment with TMC 435, but it is a pathway to licensing, and we'll pretty soon also see some data with TMC 435 in interferon-free regimens, but this will be the way we'll get access to TMC 435. So it looks quite interesting, and the dose that will go forward is 150 milligram, because the 150 milligram looks as though it is active against some pre-existing resistant mutations, the Q80K in particular, in some patients who fail TMC. This seems to take care of that resistant mutation, which does pre-exist in some patients by population sequencing. So there are other factors that affect response rates with interferon protease inhibitor regimens. You can see that for patients with cirrhosis F4, unfortunately the response rates are not as good either in the null response partial relapse group as they are in individuals who have mild fibrosis. And this is a trend that's emerging. We don't know why interferon is less effective in patients with cirrhosis. There could be many explanations. There could be shunting, it could be the age of the patients, could be the viral quasi-species, could be expression of interferon receptors on the hepatocytes. We just don't know. And there are many other explanations. I haven't time to discuss those, but interferon works much less well in patients with cirrhosis, and the same is true for TMC 435. Despite its potency, it is less active in null responders with cirrhosis. That's not the way forward. The key question is, how will we do with interferon-free in patients with cirrhosis? So the pharma set now, Gilead studies all have nuclear names that blow you away: atomic, nuclear, fission, electron, quantum. They're all meant to blow you away, and probably they do. But essentially, atomic is an important study because it looks at 7977, which is an NS5B nucleotide polymerase inhibitor, a very potent inhibitor which gives 5-log suppression within a few days of treatment, with a very high barrier to resistance, and also metabolized not by the liver but by the kidney. So in atomic, what was done was to look at reasonable numbers of patients in the study with peg-ribavirin given for 12 weeks, given for 24 weeks, or given for a short period of time, and depending upon the rapidity of response, a tail of 7977 or 7977 plus ribavirin. Most of these patients did not have cirrhosis, and of course these are genotype 1 naive patients. And this is what blows you away, because what you're seeing here was 7977 plus peg-ribavirin, a straightforward protocol of 12 weeks, really 95% SVRs across the group. And that's SVR 12. Maybe a little bit premature to think about SVR at 12 weeks as a true manifestation of SVR, but that's what we're living with, and that's what the FDA has accepted, and it is accelerating trial development. So that looks pretty good. 12 weeks was as good as 24 weeks. You don't really need the 24 weeks. Remember, this is an interferon-based regimen with a potent nucleotide, and you don't need that tail either. And the question arises, this should be one of the cheapest regimens out there. Peg interferon will come off patent quite soon. Ribavirin is pennies. You're just adding the cost of 17977. 7977 is supposedly a pan-genotypic drug. It's active against genotype 4, genotype 3, genotype 2, you name it. Genotype 1, of course, is shown in the study. And it may be, if some patients can accept just a 12-week interferon regimen, they're interferon-fit patients, irrespective of their IL-28 type. They're young, they would accept treatment. This would be fairly palatable and affordable. So I'm not sure that we can entirely divorce ourselves away from the idea that all regimens will be interferon-free. We'll talk about that in a moment. Will we have better, more tolerable interferons? There's still some interest in lambda interferon. It's been developed by BMS. Lambda interferon utilizes a different receptor. It turns out that there's much less hematologic toxicity with lambda interferon. Because there are fewer receptors, you don't get a decline in the hemoglobin, and you don't get a decline in the white cells and platelets, and that could have some applicability. Unfortunately, you still get the psychological side effects with lambda interferon. Those are not negated, so you still get depression and other manifestations of interferon. There are questions being asked about its potency and efficacy, but you could imagine that there are a group of patients with thrombocytopenia, neutropenia, anemia, for example, where lambda interferon could be useful. We don't have all the results. This is a genotype 2-3 study. This is the control arm with alpha. The results are a bit puzzling. They probably, depending upon the dose that's being used, and actually high bilirubins and transaminases have been reported at 240 micrograms, so we're going to stick with this dose. It does look reasonably interesting, with the puzzling finding that, in fact, that here the genotype 3 patients did better than genotype 2. That's a little bit unusual for an interferon regimen. We've not yet seen the genotype 1 data with lambda interferon, but it's possible that we could have lambda interferon in a 12-week regimen to back up some of the first-generation DAAs. Open question at the moment. So everyone's interested in interferon-free. I'm going to spend the first part of this talk just talking about the hep C mono-infected patients, and then go back to interferon regimens in some of the co-infected patients, just to give you a direction of travel. There are a number of regimens. I can't possibly mention all the studies. It wouldn't be possible. I've been very selective. I picked out a few. This is a regimen that looks at telaprevir, good old telaprevir, first-generation PI, together with VX222, which is a non-nucleoside polymerase inhibitor. The dual arms that just included 222 plus telaprevir have been abandoned because of high breakthroughs and resistance. That's not supposed to happen. You're using two drugs that don't share cross-resistance in naive patients, but in fact, the PIs quickly selected resistance. Cross-resistance didn't occur, but dual resistance did. And so because of that, these arms have now been terminated. And we're actually faced with quad regimens, a bit of a paradox, because we've got VX222 plus telaprevir plus pegribavirin for the hardest to treat patients, often the patients with cirrhosis. And that's really a contradiction in terms that we have to use these quadruple regimens, but we are where we are, and these quadruple regimens are currently being looked at in phase 2 trials. In fact, the control arms with some of the quad regimens, including telaprevir, pegribavirin, have been dropped. We've had to amend those protocols because they're not doing very well with even telaprevir, pegribavirin. So we're using quad regimens without a controlled standard of care arm, the new standard being telaprevir. But it's the interferon-free regimens with this compound that's perhaps more interesting. And again, I said I was going to nuance this presentation by just pointing out a few features. With this regimen is showing again this classical problem of lower response rates in genotype 1A patients versus genotype 1B. These are SVR4. We haven't yet got the SVR12 data, but you can see that the early antiviral responses and the complete antiviral responses are greater in patient 1B. So be it a protease, be a non-nuke, be it a NS5A inhibitor, subtype 1A is much less responsive than subtype 1B, not something we figured out in interferon regimens. Only the nukes probably negate that problem, and this is an example and will occur with TMC depending upon the dose, certainly seen with telaprevir and boceprevir. Subtype 1A is much more susceptible to develop resistance, and there are good molecular reasons for that. It takes a single substitution for resistance-associated variants to develop. So again, proceeding now with interferon-free other sparing regimens. This is interesting. This is again 7977 in Electron, which has been a rollover study. New arms were added to Electron. It becomes very confusing because as each arm answered a question, it was said in Auckland, New Zealand, let's add another arm and see what we get. And that's what's been done. It's a bit hard to follow. But what I'd like you to concentrate in this study, the numbers are very small.
797 plus PEG ribavirin, but this arm, the purple arm, 7977 plus ribavirin in genotype 1 null responders, and perhaps concentrate on this arm, 7977 plus ribavirin in the genotype 2, 3 prior treatment failures. So what do you think happens? It's all very good here when you've got genotype 1, 2, and 3 naive patients. Again, in these very small studies, these figures can't be real, but 100% actually have an SVR. But if you look down here, that purple arm I told you about, where you've got genotype 1 null responders, retreated with 7977 plus ribavirin, no interferon, just that regimen, the response rates are proving very poor. Now, that's not supposed to happen. These, after all, are null responders to interferon. We framed null responders. They had a less than 2 log decline in hepatitis C RNA at 12 weeks of treatment with a PEG interferon ribavirin regimen. But it's all couched in terms of that interferon sensitivity, the innate response to interferon. Why, when you come in with 2 oral drugs, 7977 plus ribavirin, you get such poor responders? Well, we don't know. It may be this treatment regimen is much too short. We haven't cleared hepatitis C from the liver. It may be that the same innate immune response that determines that responsiveness to interferon and the activity and expression of the interferon-sensitive genes and that signaling cascade by which interferon actually works as an antiviral agent is also active. And if individuals have an impaired innate immune response, they will fail treatment with this regimen as well. There's one other caveat, and these individuals have failed ribavirin as well. And I was in China last week, and Steve Feinstein has developed a cell culture system model. It's not difficult to grow hepatitis C in cell culture, and hepatitis C in cell culture is very sensitive to ribavirin. It wipes out the virus. That's not the case in humans. But ribavirin, amongst its activities, is an NS5B polymerase inhibitor. It's a guanosine analog. And it's possible that ribavirin-resistant mutations have been reported. And in his cell culture system, he reports an S15N. And I wonder whether we have possibly overlooked that some of these individuals have got ribavirin-resistant mutations. If you give them 7977 for 12 weeks, it's not enough. We don't know that, but it may be very low-level resistant mutations that take a long time. We're not sure, and watch that space. So amongst most of the exciting data, and I think you're probably aware of it, has been the declatosphere and 7977, an excellent cooperation between BMS, who have developed an NS5 inhibitor, a very potent NS5 inhibitor, and Gilead Sciences, who bought 7977. What they did in 6 arms was to look at declatosphere in genotype 1, 2, and 3 patients, all naive, without cirrhosis, and combine these agents. And it was a slightly complex protocol. There was an insistent that 7977 was primed, given for 7 days, or not given for 7 days, and then declatosphere was added. Don't focus too much on that. It really is a combination of 7977 plus an NS5A inhibitor, all oral, no interferon, with or without ribavirin. And in the genotype 1A or 1B patients, in fact, this looks like an excellent regimen with SVR4 preliminary data of 100%. Not quite as good with the genotype 2, 3 patients, not quite sure why, but perhaps the NS5A inhibitor is a little bit more likely to select pre-existing mutations in patients who have genotype 3. That's a possibility. So this looks excellent, but the problem is that's not going anywhere. BMS and Gilead have severed their relationship. Gilead have their own 5885 NS5A inhibitor. They are set on developing 7977 with 5885. So declatosphere will have to be combined with other, hopefully as potent nucleoside inhibitors. Inhibitex have such a drug. But it is a pity because this would have been fairly early on an important cross-industry collaboration that might have been useful. We won't see that again. So there's a press release on 7977 with Quantum again, pointing to the fact that you cannot be too ambitious at this stage of our understanding. We don't have the full data, but 7977 plus ribavirin given for a short period of time in cirrhotic and non-cirrhotic naive patients with 1, 2, and 3 has actually performed very poorly. Of the limited data that has been released in this press release, it looks as though only around 60% have actually remained RNA undetectable. So I think the idea that all patients could be treated with 7977 plus ribavirin for a very limited period of time, just 3 months, is probably being thrown out the window. There are possibly some patients who could be treated. Many other patients will need a longer treatment period. And we know very, very little about many of these new all-oral therapies in patients with cirrhosis and prior null responses. So we do need much more information. And again, I said I couldn't give you the lowdown on all of these trials. There are a number of new Abbott trials looking at a ritonavir-boosted protease inhibitor together with a non-nuc plus ribavirin. They look quite interesting. Here's arm 1 in the naive patients, arm 2 with a slightly higher dose of medications, and arm 3, which looked at prior non-responders. And unfortunately, what you can see that although the results look very promising, and again, these are preliminary results in the naive patients with all oral regimens giving high SVR rates up in the 90s, depending upon the dose that's used, when you look at the non-responders, only around 50% response. Again, attesting to the fact that with all oral regimens in prior non-responders, there's something missing here, and it may be the innate immune response. So we have to watch that, and much more work is needed. And resistance has been developed. Again, that's not supposed to happen. These are drugs that don't share cross-resistance, but we are seeing dual resistance as emerged in this study. Green means undetectable, but in this very careful plot in both 1A and 1B patients, you can see that several patients have developed resistant mutations. So it looks favorable, but much less so in the prior non-responders. Just to point out that there are other regimens. This is a protease inhibitor, Boehringer Ingelheim 335, plus a non-nuc 127, with various arms of the study, all interferon-free, containing ribavirin at different doses. And I'd just like to focus on this dose because this will be the dose that goes forward. I think it's 150 milligrams given twice a day, which in this preliminary analysis gave 68% SVRs. But what you see here is, once again, the weakness of a protease and a non-nuc regimen where 1A looks very exposed, only 40% in this interferon-free regimen, showing SVRs with the best dose and BID dosing compared to 1B. And if you further subtract that further and look at the IL-28BCC, it looks like the 1As who have an IL-28BCC, a favorable type supposed to determine response to interferon, actually do quite well. But the, did I say 1A? I meant 1A with CC. But the 1A non-CC don't do well. So here you have a somewhat clumsy regimen, if you like. You've got a regimen that will work very well for 1B, irrespective of IL-28B type, but you have a regimen that only works for 1ACC. Will such regimens cut it? We're not sure. It looks a little bit clumsy. So, as I said, C and CC. So where are we? This is a loose prediction. I'm almost certainly going to be proven wrong, but I think this is the way I see it. And of course, there could be more rapid development of some regimens, or some regimens could be retarded because of unexpected toxicity. But where we are at the moment is, I think, a next wave of treatment in the mono-infected patients. We're certainly looking at a number of 12-week PEG ribavirin plus DAA regimens, and I tried to show you some of those. TMC 435, MK5172, you name it. There are a number of very interesting next wave drugs which, combined with PEG ribavirin for 12 weeks, will all give roundabout 90, 85%, 90% SVRs, short interferon regimens that may be tolerable. Some of those regimens look good for genotype 1. They look good for genotype 4, for example. The protease regimens not for genotype 3, unfortunately. So they look quite promising. At the same time, everyone's going all out to try to refine the interferon-free regimens, and I showed you some of that data. And it looks a bit clumsy. It looks like there are a group of individuals who could be, for example, treated with the Clatesvir plus isanaprevir, a good regimen for 1B, not good for 1A, or 7977 plus an NS5A inhibitor, a good pan-genotypic regimen. No need for ribavirin, fairly short regimens. And these we'll see quite soon, and they probably will overlap with some of these classical regimens. And I guess gradually these regimens are going to displace those, except in an environment where reimbursement resources may be a problem, and some countries may still elect to keep interferon as a 12-week regimen together with one DAA for their patients. That's a possibility because of cost. At the same time, we're still wrestling with quadruple therapy, a full house of interferon, ribavirin,
plus an NS5A or a non-nuke polymerase inhibitor, for example, you name it, but we're looking at a number of quadruple regimens, which hopefully we can drop and replace by better tolerated all-oral regimens. So I don't know how much overlap there's going to be from about 2015 and how it will shake out. Is there going to be one crowning regimen involving 7977? Is COS going to introduce competition into this so that you have ritonavir boosted regimens, which may be forced to be cheaper? We shall see, but it's interesting days. Certainly equal efficacy plus fewer side effects, and equal cost is a no-brainer, but it's the cost that will concern us all, I think. So I think most of you know the recent trials in HIV, HCV co-infected patients, and can I race through these at great speed? But there are 2 published studies which have given us some interesting information. They are interferon-containing regimens. We're lagging behind in the co-infected group, but I think there's a lot of activism in the area, and we should see many more trials emerging. But essentially, in the telaprevir trial, which included telaprevir plus peg-ribavirin versus peg-ribavirin for a period of 12 weeks with a classical concluding tail of peg-ribavirin depending upon response-guided therapy, in patients who did not have an ART regimen versus a second arm in patients who did have an ART regimen, and that's the ART regimen, efavirenz, tenofovir, FDC, etc., shown here. These are the basic demography of the patients. You can see there were very few patients who actually had cirrhosis, none, some had bridging fibrosis, but you can see the difference between the control arms. Both 1A and 1B were included in this. Again, these are the Part B demography. Unfortunately, not enough patients included who have cirrhosis, but the response rates are interesting, and I think should encourage us to see more treatment with both the first, next wave, and true second-generation drugs. But it looks as though, depending upon the regimen that was used to accompany HIV treatment, 74% versus 45% of individuals in the peg-ribavirin arm have had SVRs. So these are much better than the SVR rates that I think you are seeing in genotype 1 co-infected patients treated with peg-ribavirin. This is quite a good response rates. Many people reported lower response rates. It's probably due to a mix of factors, including the low numbers. That's pretty good. Fortunately, the severe rash has not yet been reported, although the numbers of patients are small. Only moderate rash was seen. Anemia, as expected, and these are the shifts in hemoglobin, with around 11% of patients needing blood transfusions compared to 5% in the control arms. And because this is a Tebatec drug, we're starting to see some emerging DDI, and we'll have to keep pace with this, and you know the field much better than I do. But these are 2 non-nukes, I guess, developed by Tebatec to look at DDIs. This is the treatment protocol. It's healthy volunteers, not co-infected individuals, clearly. The PK were analyzed, and I think it looks quite encouraging for this particular combination of drugs in that there was no clinically relevant effect of etraverin on telaprevir, so it won't affect, hopefully, the hepatitis C or HIV and breakthroughs. Much more work has to be done in this area, and this is clearly a recommendation of the FDA. We've lagged behind in some of the drug-drug interactions that would be required. And incidentally, we'll have to see much more drug-drug interactions when we start to combine all oral regimens to see whether, in fact, there are, in drugs that are metabolized by the liver, some effect. So this is a list of that, again, it's a field you know better than I do. We're going to have to get to grips with this kind of information. These are the kind of recommendations that exist for telaprevir with HIV antiretrovirals, and here you see them. So for efavirenz in particular, telaprevir dose to 1125 milligrams, as I think you know, is required. No dose adjustment for raltegravir. Some more information required on tenofovir, and some studies have not been concluded, with a number of drugs that have not been recommended. So reasonable state of the art. Similar data has been obtained for boceprevir. The trial design is very different. The numbers were actually a little bit larger in the boceprevir study. There was once again a control arm of peg-ribavirin and placebo versus peg-ribavirin with the classical lead-in and then boceprevir. It was this 2-arm study with the appropriate follow-up and futility rules. These were the key inclusion criteria: CD4 greater than 200, HIV less than 50. Those were the exclusion criteria where a number of antiretrovirals were excluded.
and this is the initial results that we have. This is the breakdown in the peg-ribavirin control arm versus the boceprevir arms. Again, not enough patients with cirrhosis being included in these studies, but both 1A and 1B being included with the CD4 counts listed below. And these are the virologic response over time with SVR12 in the boceprevir arms of 61% versus 27%, more typical in genotype 1 patients with peg-ribavirin. So again, I think this is encouraging. The adverse event reports are here with a not greater serious adverse event report rate in this cohort with boceprevir, no higher rate of deaths. There were, in fact, however, some HIV breakthroughs. The figure, I think, was 4 of the 34 patients in the control group and 3 of the 64 patients in the boceprevir group had HIV breakthroughs, unfortunately. And again, I think this is something you know better than I do, but the FDA has issued a Dear Doctor letter regarding the boceprevir plus HIV boosted PIs, where there's been some concern about drug-drug interactions that may impair the activity of the antiretrovirals or conversely the hepatitis C direct-acting antiviral. And I think this is a reasonable table, our current state of knowledge of some of the drug-drug interactions that we know about with boceprevir for tenofovir, for raltegravir, where no dose adjustments are required. PIs are the problems. Efavirenz, clinical significance, not clear in those particular listings, and etravine with further research. So I'm not entirely sure whether this excludes boceprevir from the management of patients with HIV, HCV co-infection, whether it favors telaprevir, or whether there are some workarounds with the appropriate regimen. You can tell me. So I'm going to close then by just saying we're in a very exciting phase of the evolution of these drugs. I hope it proves as beneficial in the co-infected groups, the decompensated cirrhotic patients, the post-transplant recurrent patients, children, all the groups that we need to look at as so-called special groups, the dialysis patients. We're finally seeing many more studies in this regard. There are actually a lot of pending studies. So the final aim would be for oral combinations, but I'm not entirely sure that in the first move away from the classical treatment, we'll actually get away with interferon altogether, although they may shake out later. We'd like daily dosing, shorter treatment duration. We'd like drugs to be safe and tolerable with well-worked-out DDIs. Pan-genotypic would make all of our lives much easier, rather than have clumsy regimens for 1A versus IL-28B-CC. We'd like them to be IL-28B independent. We really want to see more information in patients who failed treatment, have null responses, and patients with cirrhosis, and the decompensated group and the co-infected group. And I think I'll stop there.